Hi everybody, my name is Rhys Barber. I'm one of the audiologists here at Audiology Associates.
And my name is Taylor Green, and this is it's quite a long one.
It is.
Quite a long video, and this is just one ear canal actually. And as you can see, very, very dry, crusty, very deep, very solid, compacted over the eardrum.
Yeah.
So I already knew straight away this was going to take us a little while. So.
Yeah. Always difficult when it's that dry and that deep, and it's just connected to the canal wall all the way around, isn't it? It's just not an easy one to get out.
Very, very firmly attached to this ear canal as well. You can almost kind of see, as we're just touching against this material, I'll call it, because there's a bit of a mixture of everything here, and I think this is part infection as well. Yeah. Very, very firmly attached to the ear canal. As I'm touching the side, you could almost kind of see the skin almost kind of go a little bit white. We were putting a little bit of pressure on it, but we had the standard size Zollner tube to start with to see if we can get any movement from this. Now I think I've switched to the fine end here just to try and see if I can get any.
You can see it pulling against that skin as you lift it. You can see the whiteness of the skin underneath. That is really, really firmly attached, isn't it?
And this particular patient, to be fair, absolute trooper through the whole thing. A lot of people will find this quite uncomfortable, but this particular patient just sat through the whole thing, didn't move. Well done, fair play.
I mean, with that, I'd imagine they were experiencing loads and loads of hearing issues with that.
Pretty much almost completely deaf on this side. Yeah, no hearing, or very, very, very muffled hearing in this side, and understandably. So what I'm trying to do here is getting an edge off this ear canal. Because as soon as I start peeling this away, I'm gonna introduce some olive oil. Or that's what I think I do anyway. We're gonna introduce some olive oil to try and start slipping underneath this. So we've obviously we've switched tools here now. I wouldn't recommend obviously any other. I wouldn't recommend anyone try and do this with any manual tools this deep. But because I've started to lift this here, that's what I'm trying to do here. Is I'm just you can see how solid that is.
That is absolutely solid as a rock, isn't it?
I'm like flicking off the end of it. Now I'm just trying again to see if we can just slip this underneath without causing any discomfort.
It's so difficult when it's firmly attached all the way around, because no matter what you put on there, and the surface of that just looks absolutely solid. So you're just not going to get that grip, and it's that slightly concave surface. So, you know, the microsuction tools microsuction is not going to budge that. Now,
obviously, a lot of people would probably say, "Oh, why don't you just get in there, just get behind it, and
it's just wedge it right in, just crowbar it out."
Yeah, just stand up and get underneath it. No, it's very, very sensitive in this part of the ear canal. We're basically working on top of bone here.
Yeah. And you're right on top of the eardrum as well. So you push something through that, you know, and you can run the risk of perforating the ear, and that is a real risk, isn't it, of perforating the eardrum in that. This is, in fairness to you, Taylor, this is a tough. I think a lot of audiologists would really, really struggle to get this one out, because this is.
And I did.
Yeah, do you know what? I can see this. This would just. I would just be like, where do you start with that? Because it's just nothing. It's not giving you anything there, is it?
With this, now normally we would advise olive oil in the ear in 95% of our cases, but this particular patient had travelled quite far to come and see us to get this removed. So I've introduced the olive oil, as you can see.
That's
now here we go.
Yeah.
You can see now that olive oil has already started to kind of seep underneath this. Now as soon as we've lifted it, look how wet this is behind this really dry, solid crust. What I suspect has happened here is patient's gone to the doctor. They have mentioned they've been to the GP.
Yeah.
Now, they have issued a spray. Now, we're unsure at what spray, you know, has been issued. So I assume this is some sort of antibiotic spray that has gone in here.
It's usually Optimize, isn't it?
Usually Optimize, which, we generally, a lot of the time, we see it dry things up. It's good for infection. It kind of clears infection up. But any debris left in the ear generally tends to, as you've seen on the surface, just really, really dries things out.
Yeah. It's almost like you get that wet discharge from the infection. the automize will go in. It almost forms like a crust over the top, doesn't it? And then it just solidifies. And because it was liquid to start with, this is why it's so firm. But look how wet that is in there.
As soon as we pull that dry piece away, it's just all started oozing. A lot of discharge here. This is obviously an infection. That,
not the one you want just before lunch, is it really? Or
No.
just after.
Either way.
Was there a smell to this one? Can you remember?
I don't think there was actually. No. You can a lot of the time get quite a
pungent,
yeah, quite a horrible smell, and you can usually you can usually again, any audiologist that deals with this kind of material will just know that you can usually tell there's an infection without even looking half the time, because you can just smell it. It's quite a noticeable smell.
The chap asked me the other day, do you take anything out of the ear that really flips your stomach? And I was going, no, I'm pretty good on most stuff. And he said there must be. I remember vividly when I worked in the NHS with a patient, and they had a raging ear infection, and in the NHS, the hearing aids are big moulds on the outside. And he went to try and put his hearing aid back, and he'd taken it out of his ear. You could see there was loads of really discharging infection before he put it in. He put it in his mouth and licked the outside of the top. And that was the only time I think my stomach went, whoop. We go, oh. But in fairness, we don't see it too much.
Use wipes. Don't lick your moles.
Don't look at anything that's going to work.
Oh, that's disgusting.
It's bad. But yeah, this is. I mean, this is a really nasty bit, and this is discharged right down on top of the eardrum as well. You can see that sort of crusty. We keep saying crusty, but that's what it is. It's like this. It always reminds me of. Volcanoes, we get that kind of magma, and you see, and there's really solid on the top, and there's all liquid lava underneath. Yeah. That's the kind of thing we're looking at in here. But it's gone
really
right
good
down.
analogies.
I like that one. That's not bad. I'm coming out with it. I haven't done one single food analogy.
Yeah, nice.
I'm doing all right.
You've done really well. And we literally have got lunch after this.
We have literally got lunch. I might postpone it for an hour after watching this. But it's quite deep. And they look at that.
Yeah.
And the thing is, it's really hard because you can't get that fantastic grip with this really kind of knobbly surface on this harder, crusty bit of wax, and it's wedged and stuck to the attic. Yeah. It's stuck to the eardrum probably, or the mushy wax, mushy discharge behind it.
Yeah, my kind of thought process here at this point, now that we've taken sort of half of that sort of really hard debris away from the eardrum, I've gone back in with the suction just in a hope that now that we've started peeling this away, if I can get any sort of grip with the suction, as I start pulling this, I'm kind of hoping it'll just kind of start rolling off the ear canal and just bring everything else with it.
You are lucky sometimes, aren't you? It'll just peel it. You'll see the whole thing will peel down from the top. Yeah.
We're obviously having a load of issues getting this last bit out. Patient is hearing better already, so they had mentioned as soon as you took that piece away that there was some form of hearing coming back. Still not great because we've still got a lot of that wet material sort of sat over the front of the eardrum.
So would you, like, for instance, with this patient now, okay, we've broken through the crust, we can see the eardrum beyond, we can see that discharge then. I mean, what would you do with this patient after? What would you advise this patient does if you saw this kind of discharge still left in there?
It's a GP appointment. Yeah, I would have written up a letter, sent the patient to the GP. Now that we've taken that material away, if they do reissue or issue a antibiotic spray to try and treat this, it will work a lot quicker and more efficiently as well, because there's nothing stopping this from getting.
It can get to the nub of it.
That's it. Yeah. So we're focusing on this lead edge now. So we're starting to peel this away, and we're quite lucky so far that the little bit that we have peeled away is still attached to that longer piece at the top there.
It's always brittle though, isn't it? These tiny, these thinner sections on the, sorry, scooch back, these thinner sections on the side of the canal wall, you start to peel them, you think, oh, I'm going to get a good grip, and then they just start folding and they snap because they're so brittle, they're so thin. Yeah, and the forceps are usually, I mean, you can sometimes be quite lucky and start getting a peel, but if I got a funny feeling here, if I did use like some sort of crocodile forceps, I may have just sheared that away
just making my job a lot harder, basically. So I'm just clearing up that discharge, and you can see that sort of greyish, sort of bluey tinge, and that's the eardrum actually being unveiled. Oh, is that a word?
Well, unveiled.
Revealed.
Revealed. That's the one.
Unveiled.
There you go.
Revealed. So yeah, so painstaking, these ones. I absolutely hate it. It's very satisfying when you do manage to clear it all, but so painstaking and quite taxing on your body, actually.
It is, because when you've seen the outside inside videos we've done, the movements you're making are minute, and you've got to keep your hands so steady to be able to get down there, and you're kind of in all a nervous space. The tension in your arm and your shoulder and your arm, like I found myself there, I had a full ear canal peel and eardrum peel to do today, a really thick old dead skin as well. I found myself at 3/4 of the way through, you're kind of leaving your arm down here, then the blood go back to your fingers, and then you're going to carry on.
So we've got a little bit more movement here now. That top portion is starting to move a little bit.
Thing is, you're right on top of the pars flaccida here as well, which is that thinner portion of the eardrum. So this is why we've always got to be so painstaking with it, and just take everything really slowly, really gently, because you can do some real damage if you're a bit too enthusiastic. Was that a bit of oil or a bit of hair just creeping up over the camera? I think there.
Bit of oil. Oh, it's slowly starting to go off.
Oh, that's a good one. It's just it's shearing. It's just too brittle, isn't it?
Yeah.
Oh, that is.
It's such a horrible sight. Such a horrible sight to see.
Yeah.
But yeah, where we've obviously just mentioned about that very, very sensitive part of the eardrum, where this piece is still attached, you've got the malleus bone, which basically touches everyone's eardrum. You're supposed to have the bone in there, but again, you can imagine it's so small that you don't want to put any pressure on this. No.
And you've always got that slight angle to it, so it sort of protrudes slightly. Oh, it's a bit big. Protrudes slightly through the eardrum at there, so you don't want to hook over the top of that. You imagine how you run the risk of perfect eardrum dislocating the ossicles. There's another one. You know what I mean? It's
right. We're getting somewhere.
You really want that piece to hold on now to that bit behind, don't you?
Yeah.
You don't want that to break at this point.
That's what I'm trying to do. I'm trying to fold this over slightly to that smooth little area. I'm just trying to get a little grip on that.
Do you find it always flicks back down?
Yeah, these harder.
You pull it down and it goes again. You go back in. It's back to where it was.
We are into the forceps here now that I've loosened this.
Yeah. You can get the grip now either side, can't you? See with this one, just look at the jaws either side of it.
I need to go very careful here.
Yeah, this is a slow, gentle pass. Just hope this doesn't shear off. Taylor broke. See. Yeah, there'd be various different choice words when it's reminded at this point, I think. Oh, that is so gutted.
Normally a lot of profanity in my head when that happens. Don't physically say it, obviously.
So I tend to sing to myself in my head while I do that. But it's you've left with a ridge now on that side that potentially we can get a grip on here, which is exactly what you've gone for with the fine end there. That just because where it's sheared off, it's just left a slightly thicker piece. Yeah. Oh my goodness me, though, that is so.
So frustrating. I'm so glad that this patient's other ear canal wasn't the same as this one.
Yeah, that would be worse, wouldn't it?
Oh my goodness.
Oh dear me. But that is a. Oh no, that looked like a little bit of movement then. You could just see, well, it's on the right hand side on the viewer screen, but you could just see it just pulling, just loosening from that edge. Oh, this is so difficult to do. Fair play to you.
Oh, don't forget, guys, if you do have any issues like this with your ears, just click onto our bio and information. Yeah. We've got our website that will guide you to our clinics, our telephone number. Book yourselves in, get them checked.
And if you do enjoy the videos, guys, you can always like, share, follow, subscribe, and heart.
And that.
Look at that, look. Oh my goodness.
Oh, come on. I can see there is a bit of, there's movement there, but it's, here we go,
there we go, look at the gap.
Where that move, there we go, we're going in, back in with the rosin inserter here.
Oh no, this is a tough, because you've got to get between that top section and the skin. So you're just about big enough to get the rosin inserter in there, by the looks of it. But if we can peel that down though, my thought process, if I can peel it down enough, I might be able to get the forceps on to pull it.
Yeah.
It's dropping.
I think we might do that actually. I think.
You see the skin still attached to the underside as well, can't you? Get out of the way, Oliver.
Come on.
It's nearly there. Oh, that is a difficult one to do.
As usual, guys, our faces are usually like this because it's been a few days at least since I've seen these videos, so I can't exactly remember everything that we've done. But here we go. Look at that.
Look at that. That's
gone. Really, really nicely there now. I'm sticking with this rosin inserter just to try and loosen this.
Yeah.
Oh,
it's there, I think.
Yeah.
See, what would you do now? Would you go behind with the rosin inserter, or would you forcep that?
Well, I've obviously gone in with the suction here.
Tube,
now that we've got that flat edge that we can see. Here we go. There we are.
The angle wasn't quite right for a forcep. In fairness, you'd have struggled to get underneath to get the jaw.
You might have been all right. You might have got it nice and easy anyway.
Yeah. What you do is you get a patient to tilt the head over and then wiggle them back and forth really quickly. Or if you tap them from the other side, it just falls out. No problem at all.
Yeah, there we go. So there's little tiny spots left here now. So we've basically cleared eventually this eardrum.
I mean, just even the little bits that are left there, that is really, really difficult to remove. You are bang on the malleus there. You know, I think you'd struggle to get that off. I really do.
I just wanted to really get as much as I possibly could for this patient, just in regards to the treatment afterwards.
Yeah.
I didn't want them coming back, you know, a month later saying I'm having exactly the same issue.
Well, I think you're going to go for it, but I'd be surprised if you can get this off. I really would. I think it's so close to the malleus. Yeah, that's not going anywhere.
It's not really going anywhere there.
That is wedged on there. You know, and it's like we say to you all the time, we're weighing up, you know, the benefit versus risk. You know, if you scrape along that eardrum, we might be able to get that off, but it's going to cause so many issues. And the patient's eardrum's already aggravated, which you can see on there.
Yeah, we've already been in there for a little while, to be fair. And they've, like I said, they've been an absolute trooper sitting through this. I'm quite proud of that.
Yeah,
to be quite honest,
that started off
that's.
I didn't think that was going to come out at all.
Very, very poor amount of material
rubbish,
there. But I know. I was honestly really considering not even doing one of these because there was so little there. But what have we got? Half an inch?
Yeah,
half an inch. Or probably less than that if I'd squashed it all together.
But don't forget that eardrum. Tip your little finger. We tell you this all the time, so you can imagine that, you know, just how much that was compared to the size of your little finger as well. Well, guys, thank you very much for watching our video today. We hope you enjoyed it as much as me and Taylor obviously did voicing this one over. But as always, guys, as always, guys, take care of yourselves,
take care of your ears,
and take care of one another. And we shall see you for the next video. Bye, everyone.
Bye.